Thank you very much, and it's really a pleasure to be joining you today. I'd also like to recognize two of our collaborators who are joining us very late from the Western Pacific, Dr. Ayajima and Dr. Susanna Nazveri, that I appreciate them joining and contributing to the discussion. Our project is looking at how we can strengthen the links between campaigns, mass drug administration for neglected tropical diseases and the primary healthcare services, both in looking at serosurveillance and the referral processes. And this is in 2 countries, as mentioned, at the Western Pacific. It's important to understand that the grant and this work is actually building upon a far larger project, which we call PINE, the Pacific Integrated NTD Elimination Project. And this is a 3-year undertaking supported by Takeda Pharmaceutical through their Corporate Social Responsibility Grant. And through this, we're looking to eliminate or control up to 6 NTDs in West New Britain province, Papua New Guinea, and Vanuatu. And to do this, we're looking at how we can innovatively bring together a package, an integration of multiple interventions and services targeting disease elimination, how we can document those innovations and validate them, and do this in a way that engages wide societies, whole societies in these challenging settings, challenging island settings, and also bring some specific innovations that haven't yet been taken to scale in these contexts, like triple therapy, 3 medicines given at once that has an incredibly powerful effect relative to lymphatic filariasis, for example, and scaling up strategies for scabies that are just really emerging as approaches that potentially could be taken more widely. So really on the edge of some of these areas. So this initial project to take forward the wider PINE initiative provides us an opportunity to complement it and understand actually there are some further questions that we didn't anticipate and or opportunities we can explore through the Campaign Effectiveness Grant. In terms of what's being looked at in the PINE project and therefore through the Campaign Effectiveness, it's a range of diseases, a number of them being skin diseases, and that's a place where we will actually particularly focus with the Campaign Effectiveness Grant as we go forward. So in PNG and Vanuatu, you can see, depending on the epidemiology and context, we focused. And so the problem and the background, which I've largely covered already, but the problem statement really is around this, first of all, the surveillance and the ability to have strong surveillance systems in hard to reach populations and hard to reach populations of the Western Pacific specifically. Oftentimes where you do have surveillance undertaken, it's with a single disease orientation, and that ends up leading to more costly and unsustainable approaches. So how can you have an integrated approach, and what are the opportunities and benefits thereof? Similarly, that when we think about a campaign, a mass drug administration, it is oftentimes seen as a one-off undertaking. And yet, particularly for skin diseases, the administration of medicines at that time doesn't end the story. That's not the end of the story and the relationship. In fact, particularly leprosy and yaws need a follow-up process that has to go on after the campaign. So how do you create that referral in collaboration with the primary healthcare system? And so the purpose is to demonstrate and show that how the MDA can contribute to integrated surveillance, not only thinking about NTDs, but vaccine preventable diseases, malaria, and also capturing data on SARS-CoV-2, on COVID. And secondly, demonstrate that the MDA can be implemented with a integration and effective referral process into the primary healthcare system, that those can actually not be seen as separate pieces, but complementing each other. And so the programmatic outcomes we're looking at are demonstrating the value of this, of integrated surveillance, providing evidence, particularly tailored to these hard to reach communities in the Western Pacific around the future implementation of integrated MDAs, and to create and test that natural loop that needs to be in place between a campaign and the primary healthcare setting when you have diseases being targeted that need follow-up after the fact. And this also then should inform policy and guidance outcomes. These are not one-off pieces. In fact, the beauty of this collaboration, working across the ministries in the two countries and with partners in particularly WHO and the Western Pacific Regional Office, is that it can inform and directly be part of those policy discussions around the role of serosurveillance and how we integrate that, and the operational policies for referral and treatment, particularly for skin diseases in health systems. In terms of the research questions, I've alluded to them earlier, but this slide we've also given a little bit more detail into the actual processes and steps we'll be taking. So in terms of the M&E and the integrated surveillance, serosurveillance, we'll be having a set of planned M&E activities that are actually supported by the larger PINE project. And what we're looking at is how can we extend and build upon that through the collection of dried blood spots from individuals and using then Luminex platforms for the multiplex serology. And so the serology will not only be done for the NTDs, as was the original aspiration, but particularly adding things like measles, rubella, tetanus, malaria, and COVID, SARS-CoV-2, as I said. And then closing the loop, so to speak, with the results through discussions with the ministries in the two countries in terms of what do these mean for further and future collection of non-NTD data as part of an NTD-oriented campaign and set of surveillance activities. Related to that, and this is the PHC referral part, so you may have picked up, we actually are speaking to two of the campaign effectiveness questions here. And on the PHC referral part, this critically is going to demonstrate the ability to bring healthcare workers into the process of understanding skin entities and how those will be managed and can be managed and monitored on an ongoing basis. And then using the planning for the Mass Drug Administration to actually sensitize and orient the MDA teams, staff, to work with those coming to the MDAs, which typically would reach 80–90% of people, to identify either through self-report or through identification during the MDA process where there are, for example, cases of leprosy or cases of YAS, and then having a systematic process for referring those into the primary healthcare system for follow-up, and then tracking that through into the follow-up activities over the subsequent weeks and months to ensure that the post-exposure prophylaxis for leprosy or the YAS lesions resolution is in fact completed. So closing that circle from not just treating people, but actually where there is active public health need, disease is underway, making sure that actually the health system is working with them to complete the whole course of treatment and follow-up. Project timeline, we are well on track in terms of the ethics approvals, and we are in the process then of beginning the training and planning the baseline surveillance activities and collecting the blood spots. Just about 2,000 will be collected in each of the settings. Again, this is quite a significant undertaking, and so the opportunity to do this for multiple diseases is really powerful. In October, we're looking at the timing and beginning for the MDA campaigns, and we understand there'll be a follow-up presentation through the Health Campaign Coalition. There'll be follow-up activities for the MDAs for the follow-up leprosy and YAS cases, that PHC referral element in the latter part of this year, we anticipate, and beginning part of next year, then follow up on the serosurveillance results and how do those, as well as the NTD referral processes, what do they mean for the primary healthcare programs, but also for delivery of integrated MDAs, in the Western Pacific region. And that is where the policy outcome process will be taking place. So last slide, the COVID situation is a key challenge. And so what we are working on very intentionally is to understand which of the activities actually can go forward, particularly in PNG and Vanuatu, even if COVID continues to be a growing challenge in the two countries. Vanuatu so far has fortunately been spared quite a bit, but PNG, it's been a significant growing challenge. And so we know that some of the baseline serosurveillance, for example, and even some of the referral system through that baseline surveillance we can move forward with. and do this in parallel. Vanuatu, the timing and the sequencing of the vaccine rollout and may end up delaying the MDA, in which case then we will work closely with the ministry to sequence things. A second challenge I wanted to put out there for discussion with the group is really when you're thinking about the intersection between science and public health, the needs of communities, the needs of health workers, et cetera, is how to balance those things. Because there are many questions one could investigate. There are some questions maybe that are critical to investigate, but the line is rarely, I would say, absolutely clear about just how far and just which areas to prioritize. And so it's something that we've been grappling with and thinking about which scientific questions are absolutely critical, which of them will really drive public health decisions, and which are actually beneficial to the wider scientific community, but in an implementation project, perhaps may need to be deprioritized slightly. So that's a second challenge and discussion for you all. So thank you all. And again, I welcome my colleagues to join in the discussion and follow-ups. Thank you.